lungs, and somebody might ask you, what do you think is going on? You have to figure it out. Everybody good? Alright, okay, that's 15 minutes of our time gone. I have to be out of here by 11. Okay, so we're going to talk today about food marker is this. Food?
Yeah.
You? Theirs?
No, it's Kieran's.
Yeah.
But I
Want to toss it? Alright, so we're going to talk about obstructive lung disease. We've been talking about obstruction and type of respiratory failure. Now let's talk about some specific diseases. So, this you see, I don't know why, I have to begin my lectures with some kind of anatomy. So, everybody knows this. This is the anatomy of the airway. We already talked about the pharynx, how it is divided into nasal, oral, and laryngopharynx, the vocal cords. Remember the epiglottis, right? Remember the epiglottis. I want you to remember the location of the tonsils and the adenoids because we're going to talk about infections later on. You need to be able to tell tonsillitis from adenoiditis. And then I want you to remember all of this. We talked about all this already, so I'm not going to waste too much time on that. Now what I want to talk about is we divide the airway into upper and lower airway because we're going to talk about airway obstruction, right? So in order to talk about airway obstruction, we need to know upper airway and lower airway. So anywhere from the nose down to the larynx is clearly upper airway, like we said the last time. And bronchi down is lower airway. The trachea straddles both upper and lower. So generally, above the sixth tracheal ring is considered upper airway, and below the sixth tracheal ring is considered lower airway. Very important point. Make a good note of that. You can't forget that. The sixth tracheal ring is your landmark. And I will tell you where that corresponds to in terms of the vertebrae. Okay? So, moving on. Okay, get this down to move. Okay. So, how do we then classify the airway obstruction? We classify it as upper or lower airway obstruction. Now, you see, this is your sixth tracheal ring. It's just below the thyroid. Okay? It corresponds to T1, thoracic vertebrae, the first one. Okay? And C5 is your cricoid cartilage, the superior border of the cricoid cartilage. Right? Now, upper airway obstruction is a little bit complicated. So I want you to just, don't type, don't write, just listen first. Okay? So generally, when you talk about upper airway obstruction, we talk in terms of, is it intrathoracic or is it extrathoracic? In other words, is it above the sixth ring within the chest or outside of the chest? In other words, is it enclosed within the thoracic cavity or is it outside of the thoracic cavity? The reason that is important will become clear to you very soon. And then the kind of lesions that will obstruct it, regardless what the lesion is, they can obstruct in two ways. They can cause a pliable obstruction or a rigid obstruction. When we say it's a pliable obstruction, that means it is not completely around the airway. It's partial, right? So if this is the airway, whatever is obstructing it is only partially around it. It's not completely. When it is completely around it, it's the rigid. That's why I call it circumferential and non-circumferential. It's around the tube, the airway, okay? Now, is it important to distinguish whether it is complete or incomplete circumferential obstruction? Because that really determines the severity of the obstruction and also the way the obstruction changes with inspiration and expiration. I will explain that. Just know that when it is pliable or variable, the degree of obstruction varies with inspiration and expiration. Whereas when it is rigid, it does not change. It stays obstructed, whether in inspiration or expiration. Okay? And then the lower airway is from your sixth tracheal ring down. Basically, the diseases we talk about: bronchial asthma, reactive airway dysfunction, allergic bronchopulmonary aspergillosis, chronic bronchitis, emphysema. And sometimes you have patients that have both upper and lower airway obstruction. That is so common. For instance, a good example, if I was to give it to you in an exam, I will give you, here is a patient, I would say something like a 50-year-old heavy smoker, say with 30 pack year of smoking, presents with dyspnea and exertion. And I will give you a blood gas that is reflective of chronic CO2 retention, right? And I will give you a flow volume loop that shows a specific pattern. And I'll tell you what is responsible for his shortness of breath. Is it a COPD or does he have some other condition? You see, patients with COPD, when they get COPD exacerbation and they get into the hospital, many times they get intubated and they get put on life support. Repeated intubation causes tracheal stenosis. And over a long period of time, the tracheal stenosis will cause an upper airway obstruction. And it will present with shortness of breath. If you keep giving somebody with tracheal stenosis bronchodilators, you're wasting your time. They're going to die on you. Because tracheal stenosis needs to be dilated. You have to put a bougie down there and dilate it. Bronchodilators don't work for tracheal stenosis, right? So that is the way that will present. So that's why I put it could be mixed in patients with multiple endotracheal intubation for chronic obstructive pulmonary disease. So this is what I was telling you. When we talk about causes, don't bother yourself. We're now going to talk more about upper airway obstruction. When we talk about causes of upper airway obstruction, basically remember, you divide them into extrathoracic and intrathoracic. Those are the two main. And then each one of them can be variable or fixed. I don't want you to bother yourself with list of causes and stuff like that. Just remember three. Is it a stricture? Is it a tumor? Or is it decompressed? Because it does not matter what is causing it. If it is a stricture, if it's a tumor, whether it's going to be variable or fixed depends on the severity of it. Right? So a stricture can give you variable obstruction in the early stage, and I give you fixed obstruction in the late stage. Same condition. That is why I put everything together. All you need to do in terms of what are the things that will cause it, remember the organ, vocal cord, oral lesions, laryngeal stricture, tumor compression, tracheal stricture, tumor compression. If it's a tube, that is anywhere from trachea down, it could be due to stricture, tumor, or compression. Okay? And now, and I give you on this side, what are some of the specific examples of stricture, tumor, or compression, right? So the list over here is actually common to any one of these. So I'm trying to make this easy for you, but I want to make sure I don't end up confusing you. It is extremely important that you understand that when it's from the larynx or the trachea, it could be due to stricture, tumor, or compression. And any of those could be papilloma, lipomatosis, myeloma, carcinoma. Strictures can be glottic stenosis, tracheal stenosis, like we said. Compression, it could be due to goiter, it could be due to hyoadenopathy, bronchogenic cyst, mediastinal mass, or even vascular leaks. Okay? And the same way, when it is fixed, it could be due to brachial tumor or compression, extrathoracic. Okay? And intrathoracic is exactly the same causes. But now, there is something very strange about upper airway obstruction that is intrathoracic. And I will explain that to you in picture. But just to see what this is. An example of a variable intrathoracic upper airway obstruction is tracheomalacia. Tracheomalacia is a pathology where you have softening of the tracheal cartilage. The tracheal cartilage is so soft that the airway collapses during inspiration due to weakness of the tracheal cartilage. Okay? And when it is fixed, it could be due to stricture, tumor, or compression of the same trachea, but this time below the 6th trachea ring. This slide looks busy, it looks complicated, but I hope you already realize it's very simple. All you don't need to memorize any specific causes. Just know that upper airway obstruction can be intrathoracic when it occurs within the thorax, or extrathoracic when it's outside of the thorax. And in either of those cases, it could be variable or fixed. Okay. Now let's talk about what that really means. Why do we pay attention to that? So look at an extrathoracic obstruction. See what it does to airway. When the obstruction is outside of the thorax, right? During expiration, there is positive airway pressure, right? Pushing air out. That positive pressure distends the airway and the obstruction is less in expiration when it is extrathoracic. But during inspiration, there is negative pressure inside the thorax. Have you heard about Bernoulli effect? Are you familiar with Bernoulli effect? Okay, let's not go there. Now, right, when there is negative pressure in the thorax, the airway above will collapse. Right? What happens if you just create a negative pressure in a can, an empty can of Coke? What happens? It collapses. Right? When there is negative pressure, because this portion of the trachea is not within that negative pressure, it does not distend with it. Rather, it collapses above it. So the obstruction tends to be worse in expiration, in extrathoracic obstruction. Okay? Whereas the exact opposite happens in intrathoracic obstruction. When there is in intrathoracic obstruction, because the obstruction is within the thorax, it is subject to the negative pressure changes within the thorax. So when you have expiration, when the airway is collapsing and creating positive pressure, the obstruction tends to be worse. Whereas during inspiration, when the airway is distending, the obstruction tends to be better. You see that? It makes sense, right? Good. This here is very important that you understand it. So in extrathoracic, the obstruction is worse in inspiration. In intrathoracic, the obstruction is worse in expiration. Right? You need to look for a way to remember that. Okay? I will tell you how you can remember it when it's time. So this right here is to explain what I said in the previous slide, the last two bullets in the previous slide. But really, how does airway obstruction manifest? Noisy breathing. Airway obstruction. Noisy upper airway, noisy breathing. It could be snoring, and the medical term for snoring is stertor, or it could be stridor. They are not the same thing. Stertor is straight snoring. Okay? Stridor is a different kind of sound. We'll talk about that later. Then there is voice changes. There are two kinds of voice changes. There is muffling, when the problem is above the glottis. So the people talk as if they are muffled in their mouth. They sound muffled. Okay? And then there is hoarseness. Okay? When it's a laryngeal lesion. So when somebody presents with voice changes, it is extremely important for you to ask to document what it is, because you can. If somebody is sounding muffled, you say it's muffled. If somebody is hoarse, you say it's hoarse. Don't just say voice changes, because when you say voice changes, you really put yourself in a bad corner. Because when you say somebody has voice changes and your preceptor asks you for differential diagnosis of the voice changes, then you have to come up with differential diagnosis for muffling and hoarseness. But if you say hoarseness and they ask you what is the differential diagnosis for hoarseness, you're limited to only a few conditions. Okay? Extremely important that you describe things precisely. And then you have chronic cough. Chronic cough, notice, chronic cough is very specific for intrathoracic lesion. Okay? You have shortness of breath. You can get shortness of breath in upper airway obstruction, but the severity of the shortness of breath depends on the tracheal diameter. Okay. If the lesion, it could be stricture, it could be compression, whatever, compresses the trachea to less than 8 millimeters, normal trachea at the thoracic inlet is about 18 millimeters plus or minus 1.2 in men, or 15 plus or minus 1.4 in women. Whenever trachea diameter is compressed to less than 8, the patient is going to experience shortness of breath on exertion. Okay? And when the trachea is compressed to less than 5, they will be short of breath at rest. Okay? Extremely important. I go this detail to kind of give you a very good background on how to assess severity, because in airway obstruction you need to be able to make accurate assessment of the severity. It determines whether you call 911 or you send the patient to the urgent care or you send them home and tell them to see you next week. So throughout this course we're going to be talking about severity assessment. Make sure you understand it and you remember it. Okay. Now, when you go, so these are the symptoms: noisy breathing, voice changes, shortness of breath, chronic cough. Okay. When you examine the patient, most of the time the lungs are clear because the problem is not in the lungs. So many times you can make diagnosis of upper airway obstruction by just walking to the bedside and looking at the patient. Because you can see stridor. Stridor is noisy breathing. You have to listen to the stridor to see, is it only during inspiration or is it in inspiration and expiration? If stridor is on inspiration only, that means it's an extrathoracic lesion. Okay? If stridor is in both inspiration and expiration, that means it's likely to be an intrathoracic lesion. Okay?
Why is that?
Why is that?
Yeah,
well, because if it is extrathoracic, it is worse during inspiration, right? Because of the collapse, right? Right?
Yeah.
And when it is intrathoracic, if it is severe enough, even when in inspiration, when the lungs are distended, if it is severe enough, it will still obstruct the air, right? And definitely it will obstruct it in expiration as well. Okay, so generally speaking, inspiratory, the way we describe it is inspiratory stridor or expiratory stridor. So I hope I never hear you write or describe stridor without characterizing it as to whether it's inspiratory or expiratory. You know, when you go to your clinical rotation, you send your write-ups, and I'm going to be reading those for you guys. I never was involved in it, but I'm going to be involved in it now. I will score you negative if you describe voice changes loosely or you don't specify stridor, because I already taught it to you. Excellent. So you see what I'm saying? You see, everything we just talked about, it reflects in the flow volume loop. You see what happens to the flow volume loop when you have fixed obstruction? You see how this is, you know what this is supposed to look like, right? It's supposed to be round here, up here, and then slant down here. When you have a fixed obstruction, you see what happens? The patient is inspiring, and then instead of, so you know how that is generated, right? Where there is no obstruction, the patient takes a deep breath and it goes like that. And then that is inspiration. Inspiration comes and it's usually like that. That is the normal thing. When there is obstruction, the patient starts, but then the obstruction is limited. The flow is limited. So there is flattening on the inspiratory side. And then the expiration does exactly the same thing. So that means there is obstruction in both inspiration and expiration. That is what you see in somebody with a fixed upper airway obstruction. All right? Now, look at somebody with a variable extrathoracic. Right? You see what happens with the variable extrathoracic obstruction? You notice that the obstruction is in inspiration, right? It is because of the collapse of the airway above the thorax when the chest wall is negative, right? So the way you remember it is extrathoracic obstruction flattening the inspiratory part of the flow volume loop, right? And intrathoracic obstruction flattening the expiratory part of the loop. So it's the opposite. And now you know why this is the case, right? So if I show you this and say, tell me where a COPD patient with multiple endotracheal intubation for COPD exacerbation, and I show you a flow volume loop, I say, which one is this? You will know that is, if it's tracheal stenosis, it's more likely to be an extrathoracic obstruction, right? Okay, so you got it? So, extrathoracic obstruction will flatten the inspiratory part of the flow volume loop, and intrathoracic obstruction will flatten the expiratory part of the flow volume loop. Okay? That is a way to remember it, but you should be able to describe it. If I tell you, so why is the inspiratory part of the curve flattened in extrathoracic obstruction? Because the airway collapses above this, and it opens during expiration. Everybody clear with that? Okay. And I put this here to kind of warn you that FEV1 and FVC may be normal in upper airway obstruction, but the flow volume loop are almost always abnormal, right? So if I give you, because remember, FEV1 and FVC are really lung volumes, right? In this upper airway obstruction, lungs are really fine. The problem is obstruction of the airway, right? So pay attention to that. I can give you somebody with a history of asthma who's been intubated 3 times for asthmatic attack, and I give you a flow volume loop, and I give you normal FEV1 and FVC, because the guy is stable now. And I give you a flow volume loop that looks, say, like this. And I tell you what is the most likely diagnosis. You know, it cannot be COPD, it cannot be asthma, it's got to be tracheal stenosis from repeated intubation. Got it? So this is the way this will play out in your exam, okay? And if you just think about it, it's really fun. I mean, I just get thrilled when you're able to kind of figure things like this out, you know, because it really sets you apart. And you have to be set apart because you're from group. All right, so any questions about symptoms and signs of upper airway obstruction, intrathoracic, extrathoracic? Yes.
Okay, so on 2 slides before, you said that Stryger, it's inspiratory and expiratory, that it's a sign of
intrathoracic, yes.
So why isn't it, for that graph right there, why is it only flattened on expiratory?
Remember I told you that.
Yeah, but I get the part where, like inspiration, expiration, that, I get what you're saying, that other part.
Yeah.
So like, why isn't it showing?
Why is it not showing you?
Yeah.
Because this is showing you what the typical presentation is for a variable intrathoracic obstruction. Either of these can progress to this depending on the severity of the underlying condition. Sometimes you see a patient with wrist obstruction and you cannot tell whether it's intrathoracic or extrathoracic until you begin to do bronchoscopy, and then you see where the level of obstruction is. So when everything is severe, it's difficult to tell what is what. You have to send the patient to pulmonology, they have to scope the patient and find out exactly what the problem is. What I'm giving you is under ideal situations. This is what you will see. And usually what we test in exam is ideal situations. Okay, but a portion of the exam, about 1 to 2%, that is dedicated to confusing, chaotic situations, just to test how safe you are in practice. But most of the exam is on ideal situations, testing you. Do you understand the basics? Okay. Any more questions? Anywhere? Okay. So how do you manage this thing? Again, remember how we manage respiratory failure? Depending on whether it's acute or chronic. If it's acute, depending on what is causing it. You guys have not done ACLS, right?
No.
Okay. Depending on what is causing it, you can do the Heimlich maneuver if somebody is aspirating, right? Now, if it is acute, say somebody walked into a room and all of a sudden they become short of breath and they're swelling, or you give somebody captopril for blood pressure because blood pressure is high and you're trying to control it, and you give them captopril and immediately they start having stridor, tongue is swelling, face is swelling. That's an acute situation. Of course, you're going to call 911 if you're in the clinic, but supposing you are in the emergency room when that happens, then you have to treat it acutely with antihistamines, steroids, and give racemic epinephrine or subcutaneous epinephrine. Remember in pharmacology, why does racemic epinephrine work? Causes vasoconstriction, right? Reduces blood flow to the surface, reduces edema, and reduces the secretion, right? So this is how you treat it acutely. Antihistamines, corticosteroids, racemic epinephrine, or subcutaneous epinephrine. Okay, racemic epinephrine is usually by inhalation, and subcutaneous epinephrine is by injection. And generally speaking, you give them oxygen. And sometimes you will give what is called heliox. The reason you mix heliox with the oxygen is because if you mix nitrogen, nitrogen is heavier than oxygen, right? And nitrogen is heavier than helium. So if you mix helium with oxygen, that combination is a lot lighter than nitrogen with oxygen. Okay? So to minimize the work of breathing, you give them this heliox. I'm not giving it before, but I know it exists. Emergency room guys do this stuff. Okay, heliox oxygen is 80% helium plus 20% O2. Is to minimize the work of breathing. And if you are in trouble, your patient is not responding to oxygen, you call anesthesiologist to intubate the patient. If they are dragging their feet, you slash the patient's throat. Okay? Not with the knife like that. Usually what you do, you get a wide bore needle and you stick it below the cracker cartilage just to make a hole in the trachea for the patient to breathe while you're waiting for somebody to come and put it right to it. Okay? So when you do put the hole in the trachea, it's called tracheostomy. When you put it in the cracker cartilage, it's called cricothyroidotomy. Alright? And then when your patient is breathing and your saturation is fine, you now begin to ask them, what the heck happened to you? Right? And then you can evaluate and then you can treat. If it is a chronic condition, patient comes to you and said, my breathing is becoming increasingly noisy and now I'm short of breath. And they came from work on their way home. That is not an acute situation. So you sit down and you take a good history, you do a pulmonary function test, you look at your bulbar, you look at x-ray, you can do chest x-ray. You know, chest and neck x-ray is very helpful because when you have neck masses, they make indentation on the trachea or the esophagus. And usually on neck x-ray, you can identify the trachea by the air column in it. So if there is anything pushing against it, that air column will be indented, and you can see if there is a mass in your neck at this level or at that level. Right, so that's why we do lateral neck lesions, neck x-rays for lateral neck lesions. We do chest x-ray for mediastinal masses. X-ray are helpful for screening depending on where you are. If you're in Guatemala, you may be stuck with that. If you're in Burundi, that'll help you. Now, what you really want to do for deep neck lesions is CT scan of the chest and the neck, because that one gives you a little bit more detail. Okay? And of course, MRI is king all the time. Terribly expensive. 700 pounds in London, 1,500 in Los Angeles. Okay, so think about that for a minute. So this stuff are not cheap tests. Sometimes you have to help folks that may not be able to afford this very expensive tests. That's why I always give you the cheaper alternative. Because remember, we expect you to be able to provide quality care to poor people. We don't believe people should die sooner because they're poor. No. It's because many people are not trained to be economical. Okay? So that's why most of us, I hope, will always give you the cheaper alternative. Especially in your pharmacology classes. Extremely important that you pay attention to cost differences between classes of medications. It matters a lot. Okay. And of course, then you can't find anything when you examine. Visually, you can then do rhinoscopy, is looking in the nose directly, like that. Laryngoscopy, ENT folks do it. They use what is called laryngeal mirror. You've seen a laryngeal mirror before. It's a mirror on top of a thin rod. Looks like this. So what they do, they're very good at this stuff. They tell the patient to open, you know the way you put tongue depressor on the patient, say ah. So they use that instead of the tongue depressor. And what they do, the patient say ah, and they put the mirror against the back of the throat. And through the mirror, they can look at the vocal cord downstairs. Through the mirror. And you have to get that like less than a second glance, and you should be able to figure out what it looks like. You have to be used to seeing normal to identify it that quickly. You know? But that is what laryngoscopy, that is indirect laryngoscopy. Of course, when you see something that is totally abnormal, then you have to schedule the patient for a direct laryngoscopy when they go under, and you actually take a good look with the scope. And of course, you do bronchoscopy, and then you treat what you find. If it's a tumor, esophageal tumor, constricting, then you send them to hematology oncology. They decide what the stage is and how they're going to treat it. If it's a vocal cord cyst, like you find in opera singers, that is now big and obstructing, or is it somebody that went for thyroid surgery and the surgeon snipped the recurrent laryngeal nerve and caused the vocal cord to paralyze, such that the vocal cord, normal vocal cords will open and close. When they are paralyzed, one doesn't move. So only one moves. So the orifice into the larynx is now narrow. That will present like an obstruction, right? So you have to take a good history, you know. You guys in the fall, when you did those HMPs and stuff like that, yeah, I'm going to revamp those things and infuse them with a little bit more sophisticated cases to kind of like begin to, because the trick of this game I've realized is that in order for you not to forget many things, we have to repeat it every single time in any way we can repeat it throughout the course. So by the time you leave, you know it like the national anthem. I hope you all know the national anthem. Okay, all right. So you're all clear with this, right? Okay. So now, this is just, I like this diagram because it gives you an overview of everything I've been talking about, right? So upper airway obstruction, it could be intraluminal, that's within, or it could be extrinsic compression or distortion, or it could be stricture. Stricture could be simple web, or it could be complex. It does not matter what it is. You have to get rid of this picture. If it is, I use the word bougie. Did you guys know what I meant by bougie? Bougies are these rigid metal.
That's not what it means.
Bougie. I mean, I'm talking bougie medical term bougie. I don't know what you guys are thinking. But it's from the French. It was the French that introduced the concept of bouginage. Okay? Bouginage is a treatment when an orifice in the body is narrow. And now you introduce a plastic or a rigid metal to force it back to open. It was discovered for male after they contract gonorrhea. You know when you have gonococcal urethritis, your urethra gets carved down and sometimes causes urinary flow obstruction. The treatment for that in the old days used to be that we get this metal and we insert it into the urethra to force it to dilate. And these men have to go for this treatment every 6 months. Because once you do it now, they'll be able to live for like 3 to 4 months. By the 5th month, it's shrinking back down, and they have to go back and do that bloody thing. And it's bloody. I mean bloody as in wow. Right? So it's called bouginage. We use it for urethral obstruction, esophageal obstruction, tracheal obstruction. So you always get the bougies are lined up in sizes. So you keep going from lowest to the highest as you keep dilating. And sometimes when you have a fixed obstruction in the trachea that you can't really dilate, you get a bougie with a hole in it, we call it a stent. And you put it in the obstruction and you leave it there. So the stuff goes right through this stent, through the obstruction. You understand what I'm saying, right? Mm-hmm. So they have all kinds of weird surgical things they do. You just have to send the patient on, right? And if it is extrinsic compression, you send them for the appropriate treatment. If it is inflammation, again, you use systemic therapy, steroids, antibiotics, if it's an abscess, whatever it is. So this slide is just an overview of what you do. Because I'm hoping you're all going to be primary care, and if you're going to go into specialty, you'll become expert in these areas. But for now, my job is to teach you how to triage to the patients. Know the ones you can treat and the ones you need to send out. I think that is all about upper airway obstruction. Any questions? You're all good with that? So I have your permission to give you an asthmatic patient with repeated intubation who may have tracheal stenosis. It does not matter how I paint the picture, you will get it. If anytime you hear that somebody with an obstructive airway disease has been intubated many times, just know that there is a possibility that what they're testing you for here is an upper airway obstruction. Okay? And the way they will present it is, they will give you a history of asthma, but the indices for asthma will be normal. And they will throw something there like a flow volume loop. If that is all you have, you know you're supposed to make a decision based on that flow volume loop, nothing else. You know? Or if I tell you that an asthmatic, a COPD patient presents with exertional dyspnea and he has multiple intubation, and I show you a normal flow volume loop, and I ask you, what is his diagnosis now? End-stage lung disease, airway obstruction. Well, if his flow volume loop is normal, it can't be an upper airway. It can't be. I won't even call it upper airway. I will give it tracheal stenosis. You need to know that tracheal stenosis is an upper airway obstruction. And if I give you a normal flow volume loop, you know it cannot be tracheal stenosis because flow volume. I just told you that the flow volume loop is almost always abnormal in upper airway obstruction. Even when FEV1 and FVC might be normal, the flow volume loop is always abnormal. So if you see a normal flow volume loop, that patient does not have an upper airway obstruction. Okay. Tolu, you had a question?
About the FEV1, FVC, you said it may be normal in
Yeah.
the upper airway. So
Yeah.
is it possible for it to be abnormal?
Upper airway obstruction, when it is, remember, these are volume of air, right? Volume of air. So if the upper airway obstruction is severe and it limits the amount of air that comes out, the FEV1 and FVC can indeed be reduced. But most of the time, they are normal. By the time the upper airway obstruction progresses to the point where it's beginning to reduce your FEV1 and FVC, your patients don't wait to get that sick before they come to you. You got that? Okay. We're good, right? I'm moving on. No breaks. This trailer has no break. So we're going to talk now. So that is all about upper airway obstruction. It's very simple and straight, right? It's all about strictures, compression, and tumors. It's all about variable fixed, flow volume loop, expiratory flattens inspiratory portion of the flow volume loop, inspiratory flattens the expiratory portion of the flow volume loop. That's all you need to know. And it could be mixed in asthmatic or COPD patients with repeated intubation, secondary to tracheal stenosis. That's it. Or I can give you another example of, say, somebody with history of GERD, reflux. You know, when people have GERD, they regurgitate gastric acidic content into the airway, and they can get tracheal stenosis from that. So I can give you, that is rare, you know, but I can give it to you in an exam. Okay. Okay, so now that you have no question, let's talk about bronchial asthma. Bronchial asthma, generally called asthma, is not asthma. It's asthma. It's a chronic inflammatory disease of the respiratory tract. It is characterized by bronchial hyperreactivity and lower airway obstruction. There are two types. There is the extrinsic and there is the intrinsic. Extrinsic is usually of childhood onset or early adulthood. Usually there is a personal or family history of an extrinsic substance, an allergen that brings it on. The patient has other histories of allergy, and when you do skin test, you will see positive skin test. And if you measure the IgE levels in serum, it will be elevated. Extrinsic is called extrinsic because there is an outside irritant that precipitates it, that the patient is allergic to. Okay. Intrinsic is called intrinsic because we think it's some internal derangement of the immune system. Nothing on the outside can be identified to precipitate it. You see that in adults. Usually there is no family history. There is no recognizable allergen. IgE levels tend to be normal. And the symptoms tend to come after an emotional reaction, exercise, handling of some chemicals, or even taking aspirin. The thing about it, the reason we cannot call this an extrinsic is because in extrinsic, they have a specific chemical that will precipitate it. It could be perfume, it could be whatever. Okay? So risk factors and environmental triggers, endogenous factors, genetic predisposition, atopy, that's allergy, airway hyperresponsiveness, gender, ethnicity, I don't know, and look, we always try to put color in everything. Ethnicity is question mark. I don't think there is any particular ethnic group that has more asthma than others. Now, asthma can also be as a result of poverty, you know, like kids that live in not so clean environment, where there are bed bugs and stuff like that. Yes. If you get a bed bug into your airway, you definitely will present like you have asthma, right? Okay, so you have mold. Yeah, guess where you are likely to find mold? It's not in Westwood, more likely in in Compton, right? In the apartment. Falling. Yeah, you may get that in Westmore. Pets, roaches, dust mites, acute changes in weather, smoke, cold, strong smell, exercise. These are all things that can actually trigger asthma. Environmental factors, indoor allergen, outdoor allergen, occupational sensitizers, passive smoking, respiratory infection, and early viral infections. These are all things that could precipitate asthma. Why do we care about these things? Because if you can identify it, you can advise a patient to avoid those things. Well, do you really need to tell them that? I think most of them would have known and avoided them in the first place. But you'll be amazed. Sometimes patients don't connect their health to the environment. You see, the mother will bring a baby in her arm and she'll say, I don't know why he's having trouble breathing. You don't know. You're smoking and blowing the smoke in the baby's face. You say you don't know why he's having trouble breathing. You'll see that in practice sometimes. People are not just able to connect. But really, what is the pathophysiology of bronchial asthma? It's all about inflammation. Look at the normal airway. This small segment here, when you blow it up, you see how the alveolar looks. These are the alveolar sac, the alveolar walls, right? You see, it's free. There is supposed to be nothing here but air. See what happens to this portion in asthma. I want you to realize that the problem in asthma is not in the alveoli. It's in the respiratory bronchioles, right? See, look at the normal respiratory bronchiole. You see the normal airway, see how free it is? It has smooth muscles, it has blood vessels, the mucosa is not particularly thick, just right. In asthma, see what happens? The vessels dilate. When the vessels dilate, blood flow increases to the mucosa, and then fluid exudation at the arterial end of the capillary exceeds the venous reabsorption, the reabsorption of the fluid at the venous end. So the fluid lingers in the mucosa becomes edematous. In addition to that, the goblet cells that make the mucus, they produce, you've done this in pathophysiology, right? Right? Did somebody talk to you about goblet cells?
Yes.
Okay, yeah. The goblet cells that make mucus, they also respond to these inflammatory mediators, and they begin to make very thick, viscous mucus. That is the problem with asthma. You decrease the lumen, the muscles contract because they get irritated. The inflammation of the airway and the infiltration of this mucosa by cells. So it goes from this to this. And people will have trouble breathing here. Okay? So how does it present? Very simple. Coughing, wheezing, chest tightness, and shortness of breath. That's it. They come coughing. If it's really bad, they will be wheezing. Their chest will feel tight, and they are short of breath. Asthma, very important. All of these are not always present. Sometimes it's just cough. And you have to talk, and most of the time it's dry cough. That's it. Keep having this cough. Then when you listen, you hear it. Wheeze is what the patient complains of. Bronchi is what you hear through the stethoscope. Okay? So now when you see a typical asthmatic patient, they come with coughing, wheezing, chest tightness, and shortness of breath. When you examine them, they're usually tachycardic. They're tachycardic because of hypoxia. Okay? When asthma is severe and there is hypoxia, the heart will respond with tachycardia. Alright? They're usually tachypnic and they are dyspneic. So they come in with respiratory distress. Okay? When you listen, you hear a wrong guy. And the The pitch of the rhonchi that you hear is actually indicative of the severity of the asthma. If you listen to somebody's lungs in asthmatic attack and you hear, that's a bad asthma. But if you hear low pitch rhonchi, means the airway is already opening up. So generally, before you give them the updraft or the updraft treatment, you hear. When you go back after the updraft treatment, you hear low pitched. Low pitched rhonchi means it's responding, because that is what happens before the rhonchi disappear. And remember, a rhonchi is an auscultatory wheeze. So you don't tell that your patient presents with rhonchi. Your patient can never present with rhonchi. Your patient can present with a wheeze. When you auscultate the chest, when you listen to the chest with your stethoscope, then you will say, oh, high-pitched rhonchi all over the lung fields, or more on the right and the left. Okay. Now, when asthma leads to respiratory failure, it is usually type 1. Okay? It is usually type 1 respiratory failure. PCO2 is usually low. A normal PCO2 in a patient with acute asthmatic attack is a bad thing. Okay? I'll say that again. You can never forget it. A normal PCO2 in a patient with asthma is a very bad sign. Okay? Because asthma is supposed to give you type 1 respiratory failure. PCO2 should be low. If PCO2 is normal, that means your patient is about to go into CO2 retention. The respiratory failure is going from type 1 to type 2. That means not only are they unable to get in air, they are not able to get out air sufficiently. That is a very bad thing. And whenever that begins to happen, if you don't recognize it and you watch, the patient goes into central cyanosis. That means now oxygenation of the blood isn't there. Okay? And saturated hemoglobin percent is more than 5 grams per deciliter. Remember? That's the condition for central cyanosis, right? Okay. Now, by the time your patient develops central cyanosis, actually I should flip this, because central cyanosis is the last thing. Before they go to central cyanosis, they develop what is called pulsus paradoxus. What the heck is pulsus paradoxus? Have you heard that before? Okay, so listen to me carefully. Because many people don't understand pulsus paradoxus. And even when you read books, even written by, there was a time they asked me to write a book chapter for a cardiology textbook. And the guy was writing something on shock. And I was reading what he was writing. He really did not understand what the heck he was talking about. And I called the chief editor and told him, I know it's not my business, but have that guy that wrote the shock chapter take a look at what he was describing as pulsus paradoxus. So let me explain to you. I want you to understand it so that when you read, you will understand, you can gauge the understanding of who is writing what you're reading. You see, pulsus paradoxus was a term that was developed in the early days of medicine, when doctors used to rely only on their senses, feel, look, smell. We know that if you put your hand on your radial artery and you take a deep, slow breath, your pulse rate increases. Do that. Put your hand on your radial pulse. Take a complete expiration, and I'll breathe in slowly and pay attention to the frequency of the pulse. You see that there is a slight increase with inspiration. You feel it?
Yeah.
That is normal. When you begin to get a decrease in the pulse rate with inspiration, that was what was described as paradoxical pulse. That is the paradox. The fact that it did not increase with inspiration, but rather decreased. That is the paradox. That is why it is called pulsus paradoxus, meaning paradoxical pulse. A pulse that is behaving abnormally. Now, because as clinicians evolve, we are becoming less sensitive. We don't use our senses anymore. Especially in the United States, we're becoming more technical. See somebody who presents with shortness of breath, and the clinician will order a chest X-ray before listening to the patient's chest. That is why the cost of healthcare is increasing. Ideally, you should listen to the patient's lungs and decide whether you need to do a chest X-ray. And not only do you decide whether you need to do a chest X-ray, actually you should know what you're looking for in that chest X-ray. So that when you order it, you go straight to see what you're looking for. That was how medicine used to be. But now we have become so technical, and the people that are pushing this technical aspect of medicine are the companies that make all these devices that we use, right? So they say, well, you know, it's very difficult to appreciate the decrease in pulse with inspiration on patients, especially when they're obese and you may not be able to feel that. So let us put a number to it. It is easy to put a number to it if you understand why the pulse decreases in the first place. So let me explain to you, why did the pulse decrease in the first place? It's here. When you have anything at all that put pressure on the heart, cardiac tamponade, pericardial effusion, restrictive cardiomyopathy, acute myocardial infarction, cardiogenic shock, bronchial asthma. Bottom line, the only thing that they all share in common is that there is some kind of pressure around the heart. When you inspire, you create a negative pressure in the chest. When you create a negative pressure in the chest, you increase venous return to the right side of the heart, right? At the same time, you decrease venous return to the left heart. So the right heart has a lot more blood, and the left heart has less blood. Because the right heart got a lot more blood, the septum is pushed into the cavity of the left ventricle. So there is less, the stroke volume from the left decreases. And when there is sufficient decrease in the stroke volume from the left ventricular output sometimes is so small that it does not elicit the peripheral pulse. Okay, so when the left ventricular output is so small, yeah, there will be an output in the ventricle on the left side, but you won't feel a pulse because the amount of blood that is injected is so small. That is what is responsible for the fact that the pulse, it's not really that the pulse decreased, it is just that some of the pulses could not be palpated. Okay? So now there is this consensus that we should define pulsus paradoxus as a systolic decrease in blood pressure of more than 10 milliliters of mercury. So by definition, diagnostically, pulsus paradoxus is a decrease in systolic blood pressure by more than 10 millimeters of mercury with inspiration. Okay? But the term itself, pulsus paradoxus, was originally described based on the fact that the pulse rate decreases with inspiration. Okay? So many times you look at And in fact, I was reading a textbook, and the very first sentence is, pulsus paradoxus has nothing to do with pulse, and it has nothing to do with paradox. I'm like, you are such an idiot. That is not how to introduce that subject, because there is a reason we call it pulsus paradoxus. When it was first discovered, it was to do with pulse, and it was because the pulse did not do what it was supposed to do during inspiration. As we understood it more and more, we now defined it better. But you cannot discredit the intelligence of our forefathers in medicine and say it has nothing to do with the pulse. Why did they call it pulsus paradoxus? I mean, to start any book like that is to say all the forefathers of medicine were dumb. No, they knew exactly what they were doing. And that's why I'm telling you this, because there are some very arrogant and ignorant people out there that will try to tell you things like they invented it. We have invented very few things in medicine in the last 100 years. Very few. Okay, so that's what I'm trying to explain there. Everybody clear on what pulsus paradoxus is and why it comes? It is not an early sign of asthma. If somebody paints a picture of asthma for you with pulsus paradoxus, you need to call the respiratory therapists and the anesthesiologist right now. That patient does not need oxygen and racemic epinephrine and inhalers. No, that patient needs to be intubated now. Okay? So that is a severe case of asthma. So if I tell you which of the following is an early sign of bronchial asthma, and I put pulsus paradoxus, that will be false. That is a late, little sign of bronchial asthma. Okay? Any question? So, the patient has asthma, you think it's asthma, you send them for lung function test, usually spirometry. In spirometry, we can evaluate bronchial asthma and COPD. The only difference between bronchial asthma and COPD on spirometry is the reversibility. In asthma, the obstruction is reversible. Okay, so you see the decreased FEV1 and the FEV ratio, and even after an acute asthmatic attack, this abnormality can persist for up to 3 months. Okay, so if somebody comes, and in practice you will see a lot of people, strange people, that have history of asthma and they smoke, right? And they will come to you now that they have shortness of breath. And your problem is always, what am I dealing with here? Am I dealing with asthma? Am I dealing with COPD? So if somebody tells you they had an episode 3 weeks ago, and you send them for spirometry, and it comes back reversible, even though the attack is 3 weeks ago, the reversibility of bronchial asthma can persist up to 3 months after an attack. Okay? When it is not, and what is reversibility? You give the patient methacholine or histamine, and you can demonstrate a 12% increase in FEV1 or an absolute increase in FEV1 or FVC of 200 mils in response to a bronchodilator, right? Or you can precipitate the attack with histamine or methacholine. Okay? So, but generally what we do is to look at the bronchodilator response. Okay? Bronchodilator response. So you do the volume over time, and then you do it pre and post bronchodilator, and you can see this increase. In the old days, before bronchodilator, people used to do methacholine or histamine challenge. So the patient is fine now, but they're telling you a story that looks like they had an asthmatic attack while they were on vacation, and you want to prove they do indeed have reversible airway disorder. You put them in the lab, and then you do what is called a challenge test. And in that case, we give histamine or methacholine to precipitate the bronchoconstriction. A number of people died in the process. So we don't do challenge test anymore. We used to do it. Okay? Especially if you're in Aruba, rural area somewhere. Don't give anybody methacholine. If you're in UCLA or in Cedars, give them methacholine because we can handle whatever comes. But generally speaking, people don't do those challenge tests anymore. We do this bronchodilator response. Okay? Now, remember the first respiratory flow rate at 25 to 75%? Remember this when we talked about spirometry? There are times in asthma where the airway obstruction is more at the terminal airway than at the upper airway. It is more at the, the bronchioles, you have the bronchi, right main, left main, you have the primary bronchi, secondary bronchial, tertiary bronchial, then finally you have the respiratory bronchioles that are ultimately open into the alveoli. In asthma, not every asthmatic patient have their obstruction at the same level. Some people have their problems more at the respiratory bronchioles. Some will have the obstruction more at the secondary bronchi level. So there are times, if somebody has the obstruction more at the respiratory bronchial level, FEV1, FVC may be normal. So you have a patient that presents with asthma. They tell you, I wheeze, I cough, and I'm short of breath. But then you do this spirometry and FEV1 and FVC is normal. That is when you step back and you tell the pulmonologist, can you give me the first expiratory flow at 25 to 75%? Because that is more reflecting the obstruction at the deeper respiratory bronchial level. Okay, so when do you ask for that? Or how would I test that? I will give you a typical asthma history and physical finding, and I will give you normal parametry. What is the next thing you want to do? Chest X-ray, EKG, or FEF, 25 to 75%. That is the answer. You want to look at the first expiratory flow rate and the last 3/4 of it, because if the obstruction is deeper down, you will see it more at the FEF 25-75. Okay? You're with me, right? Excellent. Well, somebody has asthma, you have to think about other things the patients will have. So these are the common differential diagnoses of asthma. Bronchial asthma is an episodic paroxysmal problem, dry cough, chest tightness, mostly wheezing sound. If it is an extrinsic type, they have exposure to allergens. You don't really need any imaging. Asthma is a clinical diagnosis. Many mothers can diagnose asthma. Now, what else will present like asthma? Left ventricular failure will present like asthma. As a matter of fact, when left, can anybody tell me, Stanley, tell me, how does left ventricular failure, how would it present with asthma? Look at me. Yes.
Good morning.
Good morning.
You said left ventricular failure.
Yeah,
right?
tell me what is the pathophysiology of left ventricular failure and asthma, and how would it present at asthma? What would it do in the lungs that will make the patient present like they have asthma?
It's hard for them to actually get air in and out.
Yeah, that is one. But when the left ventricle fails, the left atrium cannot empty into the left ventricle, right? So you have the pulmonary venous congestion. So you end up with exactly the same thing, pulmonary edema. Now, usually, pulmonary edema presents with mucosal edema before the fluid leaks into the alveolar space. So if you catch a patient with left ventricular failure early enough, they will not have crepitations, because crepitation is produced by the movement of fluid within the alveolar sac. That's why it looks like it sounds when you hold your hair in front of your ear. It's due to fluid shifts within the alveolar sac. But before that happens, the first thing that happens is that mucosa gets edematous. So it creates an obstruction like asthma. And we used to call it cardiac asthma. Okay, so that is why it's extremely important, like David said. You screen the patient, do you have any orthopnea, any leg swelling, any PND? All you're trying to do is make sure this is not cardiac asthma. And that's why it's important to call it bronchial asthma. Because bronchial asthma means it's asthma from the bronchi. Cardiac asthma is from the heart. Okay? So extremely important. Then COPD, extremely important that you're able to differentiate between asthma and COPD. COPD is chronic, it's not paroxysmal. COPD patient is short of breath all the time. So the reason they don't come to you all the time is because they adjust their level of physical activity to their level of disease. So if they keep smoking and they used to play basketball and the disease is worse, they're not able to play basketball anymore, they stop playing basketball. They don't come to you. If they're able to walk 10 blocks, and now 10 blocks is causing problems because the COPD is getting worse, they start walking 6 blocks. They don't come to you. So, COPD is a constant disease, right? Asthma is intermittent, okay? COPD, they tend to have cough, especially when it's chronic bronchitis, and their cough is often productive of sputum. In asthma, sputum is so thick and viscous that patients can't cough it up. So most of the time, it tends to be a dry cough with asthma, okay? And of course, when you listen to COPD patients, you get all these rales. Rales are crackles. We'll talk about that, another confusing term. When I was in medical school, we call rhonchi rales, and we call crepitations crackles. They were two different things. Now the textbooks are so confusing. Some people call rows and crackles the same thing, bronchi and rows the same thing. Please understand. Rows are rhonchi. Crepitations are crackles. Rhonchi is what you hear with airway obstruction. Crepitations is what you hear in pulmonary edema. I would discourage you from using the terms rows and crackles. Do not use the terms rows and crackles. Use rhonchi and crepitations. Because when you use rhonchi, everybody knows what you're talking about. When you use crepitations, everybody knows exactly what you're talking about. When you say crackles, people have to ask you, what do you mean by that? You have to describe, start defending yourself on what you mean by that. Please use rhonchi and crepitations. Okay? And if anybody in this program asks you why are you using those terms, say Dr. Martin said so. And then I will defend why I said it. Because look, oh, you can check it yourself. Look at all the books. Look at rows and crackles. You see, if you look at 10 books, you get 10 different definitions for this. I don't want you to be confused. You should know what you mean when you say what you say. Okay?
Dr. Martin, which one is obstruction?
Rhonchi is airway obstruction. Crepitation is fluid moving within the alveolar sac. Okay? And of course, upper airway obstruction we talked about. So remember, these are differential diagnoses for asthma. How do you manage asthma? Well, before you manage it, you have to evaluate and diagnose it. If you're lucky, if you do a complete blood count in asthma, you can see eosinophilia. If it is due to extrinsic asthma, you will see elevated IgE levels. Now, I want you to read this slide correctly. So pay attention and make comments after you have understood what I mean by what I did here. Why do you do complete blood count in asthmatic patient? Because you're looking for eosinophilia. It is not because eosinophilia is a common finding in asthma. But whenever you see eosinophilia in an asthmatic patient, you should think of a complicated asthmatic patient. Okay? Whenever you see elevated eosinophils in an asthmatic patient, you should almost always order elevated IgE. Order IgE levels. Right? And if IgE levels are elevated, you should always tell the lab to give you an IgG precipitating antibody test against Aspergillus fumigatus. Aspergillus fumigatus is a fungus in the environment that colonizes the airway of asthmatic patients and produces this toxin that makes the patient have repeated asthmatic attacks that are often not responsive to bronchodilators, and you have to give them antifungals. Okay? That is why I want you to just do CBC. And the eosinophilia, I want to see eosinophilia, measure IgE level. And if IgE levels are elevated, then you should tell them to give you antibody against Aspergillus fumigatus, or send them for allergy skin test against the same Aspergillus fumigatus, because you want to diagnose Aspergillus fumigatus. The reason you want to diagnose it is because you need to give your patient antifungals. If you don't do that, you keep throwing that bronchodilators at your patient, and they're not going to get better. They're going to keep coming back. Now, why do you do chest X-ray in asthma? It's not because you're looking for asthma on X-ray. No. If you find infiltrates on X-ray in a patient that looked like asthma, you have something else. You have what is called eosinophilic pneumonia, or you have allergic bronchopulmonary aspergillosis. Are you following me? So that is how you read this slide. If you find, and you always do urinalysis in somebody with asthma. If you find proteinuria or hematuria in somebody with asthma, you need to make sure you're not dealing with Church-Strauss, which is a vasculitis. We'll talk about that somewhere in cardiology. Okay, so all of these tests, I told you earlier on, and if you look, even on my previous table, that the diagnosis of asthma, come on. See what it says? Imaging studies, non-specific, right? Generally, we don't do tests for asthma. And that is true if you, come on. Okay, that is true if your patient comes in, you give them albuterol, and they're better, and they're gone, and you don't see them again for 6 months. That is fine. That is asthma. That's the way asthma behaves. But your patient comes, you give them bronchodilator, they call you 24 hours later that they were in the emergency room, they're giving them steroids, ER send them home, and they are office 2 weeks later, not better, then you want to start doing this. Because that is not asthma. Asthma doesn't behave like that. Okay? And then you want to do serology, you want to do CBC, you want to do chest X-ray, you want to do urinalysis, looking for eosinophilic pneumonia, allergic bronchopulmonary aspergillosis, you're looking for Church-Strauss. Okay? How do you treat it? Well, it depends. See, once you diagnose asthma, you want to do severity assessment. How bad is it? And the severity assessment is usually based on frequency and pattern of attack on outpatient basis. Okay? When you're looking at the patient in the face, you're looking at PCO2 levels. I put it here again. Normal PCO2 level during an asthmatic attack is not a good thing. Okay? PCO2 of 40 in somebody with asthma is a bad thing. Okay? Even though that is normal. What you expect in asthma is a PCO2 of 30, because they should be able to hyperventilate, because they are hypoxic. If PCO2 is normal, that is a big problem in patients with asthma. Then you do the stepwise drug treatment. You give them bronchodilator. The one we use is beta receptor agonist. We talked about all of that in pharmacology, remember? Okay? And in many developing countries, they use the methoxantins. Can somebody give me the commonest one? The methoxantine loss. Give me the commonest methoxantine that we use for asthma. Aminophylline. In pharmacology? That's the only one, really. Aminophylline. Remember that? Yeah. You don't remember aminophylline? You don't remember aminophylline? The one I told you we used to bend down and give one meal at a time until your back hurts because it causes atrial fibrillation and you have to give it so slowly.
Yeah.
You can't forget this. When I go to repeat that class is a prerequisite for this class. You can't forget it. So, and you notice I'm not putting too much emphasis on medication because we already talked about this. That does not mean I won't ask you in exam. Okay? So if I say metals and things, you better know what those are. If I say beta 3 receptor agonist, you better know what that is. So you give them bronchodilators, that's the first thing you do. After that, you give them steroids because it's all about inflammation. Anti-inflammatory, steroidal and non-steroidal. So we have the leukotrienes antagonist, which you all know what to look at, not just look at. Remember those from pharmacology? Good. Now you're answering. Okay. Most importantly, you want to do secondary prevention. You want to try to see if you can identify environmental triggers and control comorbid conditions. And then every asthmatic patient must have a peak flow meter so they can monitor themselves. Peak flow meter is this thing here. Patients hold it and they blow. And usually it's about 200 and above is fine. When the patient cannot do more up to 200 when they are having symptoms, that is a problem. Okay. And usually you monitor them. And every asthmatic patient is supposed to have a self-management asthma action plan. Because they were causing a lot of problems because they go to the emergency room a lot. So we came up with something that will help us manage the patient on the phone. But we all need, for us to do that, we need to come up with a plan that the patient understands so that when we're talking to the patient on the phone, we're on the same page. Okay? And I will show you what that looks like. Oops. So you see this stepwise drug treatment. This is what it is. Step one, you see that? Intermittent asthma. Intermittent asthma is not an adjective. There is a definite classification of intermittent asthma. I'll tell you what that is. Okay? Step one, you want to use SABAs. So what are SABAs? Thank you. Give me an example. Albuterol, good. Then, once the patient is not, has gone from intermittent to persistent, then you begin to, depending on whether you are mild, moderate, or severe, the next thing you add is low dose inhaled corticosteroid. That's what the ICS is, right? Very important. In asthma, you go from SABA to steroids. Because in asthma, it's an inflammation, not so much an infection. Whereas in COPD, you go from SABA to LABA before you add the steroid. Steroid is the last thing in COPD because there is usually an infection. And you don't want to give somebody with infection steroids because steroids suppress your immune system. You need your immune system to fight infection. So steroid is not early in the treatment of asthma because asthma is not an infection. Okay? Good. So from inhaled corticosteroids, you now go to long-acting beta agonist. If that does not work, you do the medium dose inhaled corticosteroids, then you combine everything. And when you're sure that your patient probably has an extrinsic asthma and the health plan will pay for it, you can give them Xolair, omalizumab, which is a monoclonal antibody against IgE. IgE is the immunoglobulin that is mediating the allergic response. So when you give the anti-IgE, you take them out of circulation and relieve the patient. It works like magic if your patient has extrinsic asthma. It does not work if it's intrinsic asthma. Okay? And then you step it up and down as needed for your patient. The most important point on this slide is, remember, you always start with beta agonist and you add steroids, nasal. If it doesn't go, then you go to long-acting beta agonist and you add medium dose or medium intensity inhaled corticosteroids. Right. Keep going. Yes.
You said omalizumab is used for patients who have
Extrinsic.
extrinsic
Yeah.
factors.
Where there's
allergic.
IgE. Yeah. Yeah. Because Zole is monoclonal antibody against IgE antibody. You know what they do? They get the IgE antibody that is responsible for the inflammation. They take it from human, inject it into a mice, and because it's from human, the mice will make antibodies against it. Right? They now harvest that antibody, clone it, make it, and now give it to the human being that is having those IgE problems. And what it does is it just goes straight and looks for the IgE and takes it out. Okay? In an antibody-antigen reaction. Okay? What is controlled asthma? Asthma is controlled when your patient has daytime symptoms twice or less in a week, and they have no night symptom, and they are able to do everything they need to do, including play basketball, and their pulmonary function test is normal. That is what control is. If your patient has more than 2 attacks in a week, or they have any attack at night, or they are limited in their activity, or their lung function test, spirometry is not normal, they are not controlled. Okay? Extremely important. You understand what control is. So when you write your patient is controlled, you should know what you mean. Okay? So this is the asthma action plan I was talking to you about. This is an example of it. So the zones are the patient symptoms. The white zone is where what you're going to tell the patient, what you're going to tell the patient to do, right? So the patient is doing well, breathing is good, no cough, sleeping well, no problem at night. They're in the green zone. Most of the time, your patient will have these inhalers at home, right? And they can now tell them, based on what they tell you, take this singular, right? So, depending on what your patient, so you develop this with your patient in the clinic. You educate your patient on the zones, right? And I now tell them, whenever you're in the green zone, use this zone singular as needed or whatever. If you're in the yellow zone, this is what you should do. If you're in the red zone, this is what you should do. So patients know. When you now call them and they say, oh, I've done everything in the plan, it's not working, then you need to tell them, go to the urgent care. Okay? So that is what the asthma action plan does. Yeah, it educates the patient to assess their symptoms, assess their own severity, and educate them on what to do and when to seek assistance. Okay? That is not standard. That is just an example of it. Different health plans, different clinics have different action plans, different medications, depending on what is approved by the plan. Okay, so just don't look for this everywhere. This is just an example. Okay? So that is all about asthma. Don't forget, asthma is an intermittent condition. It's an obstructive airway disease. Normal PCO2 is not normal. That's part of the patient. You always start with beta agonist, followed by steroids. Usually, you don't need to do any lab tests in asthma. But when you have a patient that is not getting better, after you've given them inhaled corticosteroids and beta agonist, you need to do CBC. What you're looking for is eosinophilia. If you have eosinophilia on CBC in a patient with asthma, you want to do serum IgE. If serum IgE is elevated, you want to make sure it's not aspergillosis. Chest X-ray should be clear in anybody with asthma. When you have infiltrate, you should think very seriously of eosinophilic pneumonia or the aspergillosis. Okay? Very important. And then if you find blood and hematuria in somebody with asthma, remember shock straps. It could be vasculitis. You know, I want this. You see where I'm regurgitating it? That's why I want you to be able to regurgitate it at the bedside. I believe in you can do it. If you can do that, people will take a second look at you all the time. because it really shows that you understand clinical medicine. Because it's not complicated. In clinical medicine, all you want to do is all the time know how to treat the common things and know how to recognize the complicated things. Because that is the one that will kill your patient. The one you don't recognize. Because you won't treat it.
You go that again from the CBC.
It's in the slide, man. I said the CBC, the reason you're doing the CBC is you're looking for elevated eosinophils. If you find eosinophilia on CBC, you must then ask for serum IgE levels. If your serum IgE levels are elevated, you must then go forward to ask for the precipitating test for aspergillosis and fumigatus. Chest X-ray should be normal in most asthmatic patients. If chest X-ray is abnormal, you must ask yourself, am I dealing with eosinophilic pneumonia or aspergillosis? And if UA is positive for protein of blood, and you cannot explain it, then you have to look for Church-Strauss, which is a vasculitis.
Look for what?
Church-Strauss. All right. Okay. All right. So no more. I will assume that wraps it well for asthma. So let's talk about reactive airway dysfunction. Reactive airway dysfunction is asthma that is first time. That is wrong. That is wrong. I'm glad you didn't get that. Because what I just said is really what it is in practice. But if you say that to another person, they'll be like, asthma is not reactive airway disease. They're not the same thing. But the truth is, clinically, if somebody looks like asthma, but that is their first attack, because remember, asthma is supposed to be paroxysmal, right? Intermittent. You cannot call it asthma when it's first attack,
Right.
right? Because you can't say it's paroxysmal. So, clinically speaking, when you're seeing somebody for the first time, and they tell you, I don't know what is going on, I'm short of breath, and they're wheezing, and they look like asthma, but they don't have any history of asthma, no family history, no personal history of asthma, and everything looks like asthma. They have bronchi, they're wheezing, they're coughing. You always diagnose it as reactive airway dysfunction until you get a repeat episode. Okay? So that's why I said reactive airway dysfunction is an acute obstructive airway disorder involved following a single exposure to a high dose of an environmental irritant. Okay? So it looks like an extrinsic asthma. The only difference is that it's the first time you're seeing a patient. You can't really say it's asthma. It could just be a reactive airway disorder. I'll give you an example. There was a time my wife started burning oil in the house. And I don't like oils. So I walk in the house will be smelling weird. I don't have asthma. But then within a week, I started itching in my nose. I wake up in the morning, I'm coughing. I'm like, baby, what is this? You're polluting this. You know? I was like, oh, it's the new thing. I'm like, can we not use it for a week? And let's see. And then everything went away. Then she stopped. If I had gone to the hospital, that would have been reactive airway dysfunction. That's what I'm saying. So you will see that, just ask them, you have any history of asthma? Asthma runs in your family? No. And then, I walk in, my co-worker had this new perfume. There's a woman on this campus that if you eat peanut around her, she will get really sick. Peanut. And you'll look at severe asthma. Peanut. She doesn't have to eat it. All she has to do is smell it. And she goes straight into severe asthma. That is a case where she gets sick every single time you expose her to asthma. Is she exposed her to peanut? Is that asthma? No. Because it happens only when you expose her to peanut. So it's a reactive airway dysfunction. Okay? So you can get it from household cleaners, spray paints, bleaching agents, perfumes, pesticides, industrial irritants like fire smoke, chemical fumes, all these things. How do you diagnose it? Absence of prior respiratory complaint. That's what I've been talking about. The absence of prior respiratory complaint. You have a single exposure to a high concentration of the irritant, onset of symptom within 24 hours of exposure, non-immunologic asthma-like presentation. See that? It's an asthma-like presentation, but it is not immunologic. Okay? So they come with cough, wheeze, and dyspnea and all that. And it's persistent and repetitive. You can respond to bronchodilators and anti-inflammatory agents, but it is not asthma because the patient does not have a family history or personal history, and it's the first episode. And it's one thing that causes it all the time. Okay? So you see that, clinically speaking, reactive airway disorder syndrome and asthma, clinically they are not distinguishable. You have to take a good history to tell them apart. Okay?
Is there an age restriction when you diagnose somebody as asthmatic?
We generally don't diagnose asthma under the age of 2. That's what you do in pediatrics. A condition known as bronchiolitis. And there is a reason we don't diagnose asthma under the age of 2. Because we believe that asthma has a lot to do with mucosal edema and bronchoconstriction. 2-year-olds don't have enough muscles in their airway to constrict and cut off their own airway. They don't. So if you find what looks like asthma in children under the age of 2, it's more likely bronchiolitis than bronchial asthma. Okay? We treat it with steroids, but we generally don't use bronchodilators. Okay? Yeah. So, how might you see aspergillosis in somebody with asthma? So if you do, somebody present with asthma, it's not getting better. So one thing a good case will be, I will give you a case, 26-year-old high school rising senior in Martin Luther King Medical Magnet. I've seen you in a clinic with asthma, and you gave her bronchodilators and steroids, and she went away. The following week, the mother brought her back because she's not getting better. And what is the next thing you should do? CBC, chest X-ray, urinalysis, none of the above, all of the above. Of course, the answer will be all of the above. Now, I will now show you this X-ray. I said the X-ray returned like this. What then is the diagnosis? Aspergillosis presents in the chest X-ray with this sign called finger in glove sign. See that? Looks like somebody put their hand on the patient's chest. That thing there, that strip is called the finger in glove sign. They call it all kinds of signs. Everybody wants to give it a name. You know what is interesting about human beings? We like naming things. From the Garden of Eden, that's what we've been doing. Naming things, calling people names, and calling things names. All right? So, this same finger in glove sign is called rabbit ear appearance, Mickey Mouse appearance, toothpaste opacity, white shape opacity, this shape opacity, tram line shadowing, whatever. Right? Call it what you want. Wall, barrier, it does not matter. You can call it what you want. Okay? So just what I will call it is finger in glove. Okay? Okay? Good.
Dr. Martin,
Yes.
Did you skip a slide?
Of what? I skipped the slide.
One before. The next one.
The next one, I skipped.
You skipped the spiritual. Yeah.
I skipped this one?
Yeah.
Oh, okay, sorry. All right. So if you think seriously that somebody is allergic bronchopulmonary aspergillosis, it's because I've been talking about it, and I've talked about it for a lot of it. I didn't skip it on purpose, but you would not have missed anything here. So, aspergillosis is an hypersensitivity immune response to germinating fungal spores of Aspergillus fumigatus along the airway. The spores are in the environment. They're in this room. They're in soil. Who's likely to get aspergillosis, bronchial asthma, and cystic fibrosis patient? Okay, so if I'm going to give you a complicated case, I will give you a 26-year-old with a childhood history of cystic fibrosis. I will make him present to you like asthma, and I will make him difficult to treat. And I'll tell you what is going on. Right? You understand what I'm saying? Right? Because only these two groups of patients are at risk for aspergillosis. And the clue to this is febrile asthmatic attack. Fever is not part of asthma. So whenever you see asthmatic patients that are febrile, something is wrong. Either they have pneumonia or they have aspergillosis. Okay. And then, like I said, the eosinophilia on CBC, you can expect it in 40% of the cases, so it's not 100%, right? You can see the elevated serum IgE, right? And then you do the standard thing of diagnosis. IgG precipitating antibody is what you're looking for. Now remember this, please remember this. I did not tell you to order IgE precipitating antibodies in asthmatic patients. I didn't say that. What I said is when asthma is not responding to treatment and you see eosinophilia on CBC and you see elevated IgE in serum, then you have to do the antibody precipitating test. Okay? It's not a routine test for asthma. Okay? And sometimes when that is positive, the sputum will also be positive, right? Then you test the you see the finger in blood. Why do you really need to know about this? Because it will not respond to your bronchodilators. If you keep pushing bronchodilator, you will kill the patient. You need to recognize that you need to give this patient not inhaled steroids. You need to give this patient oral corticosteroids. And you need to give them antifungal. Very important. Because if you don't, see the bad things that happen. Bronchiectasis. You know what bronchiectasis is? Bronchiectasis is when chronic inflammation destroys the bronchial walls. And the bronchial walls dilate and begin to look like varicose veins. You know, honestly speaking, whenever you hear bronchiectasis, just think about varicosities. Have you seen people with varicosities? You see the way the veins dilate and look really ugly? That is exactly how the bronchi and the bronchioles dilate in bronchiectasis. So bronchiectasis, analogically, is really varicosity of the airway. You know why that is bad? Because when it's like that, you begin to get pockets of fluid. Wherever there is water, what happens? There will be life. Bugs will multiply. So they get bronchiectasis, repeated pneumonia, lung abscess until they form a ball of fungus that we call aspergilloma. Bad problem, and that can lead to pulmonary hemorrhage. Massive pulmonary hemorrhage. The patient will bleed out. Simple. Okay. That is why it's important that you really treat this. Okay. All right. We're good, right? Did I miss any more slide? No. Okay. All right. So now let's talk about COPD. We've been talking about COPD all along, but response of the airway and lungs to chronic irritation by noxious fumes and particles, with particular predilection for female gender. COPD is twice as common in females as males. And you know this is interesting, right? When women drink alcohol as men, they end up with more liver disease than men. Because alcohol dehydrogenase is the enzyme in the gut that destroys the alcohol and limits its absorption. Women have lower levels of alcohol dehydrogenase, so they absorb more alcohol when they drink. Okay, the same amount of alcohol, so they end up with more liver disease from drinking. The same thing happens when women smoke. they end up with twice as much COPD. And there is other things. Generally in life, women get penalized more when they try to be like men. And you need to know this, because, and the reason I need to know this is because there is this idea that men and women are equal. That is an insult. The man is made from dust. The woman is made from the man. Women are superior beings than men. And when they bring themselves down to behave like men, they get punished more. In your life, as you go through life and medicine, pay attention to disease pattern in men and women. You will see that whenever the disease is related to a behavior, women pay greater price than men do. It's very common. Okay? Just pay attention, you will see it. Alright, so COPD is the name for chronic obstructive pulmonary diseases. It consists of two diseases, chronic bronchitis and emphysema. What is the difference? Chronic bronchitis is chronic, persistent, progressive inflammation, usually in the bronchioles. Okay, that's why it's called chronic bronchitis. Emphysema is when the inflammation has now spread into the alveoli and the alveolar septa are getting destroyed. So you see, instead of having these air pockets, you're getting the walls broken down and you're forming cystic air spaces. Okay? Emphysema does not have a lot of secretions, but it has severe lung damage. And that will reflect in the way they present. Okay? What causes COPD? 80 to 90% of all COPD cases come from cigarette smoking. A few cases comes from occupational exposures to heavy metals like gold, coal, asbestos, cadmium, mineral dust, and environmental exposures to nitrogen dioxide, sulfur dioxide, and wood smoke. When you go to, if you ever join the Global Health Initiative folks that go to Guatemala, Africa, Northern Ghana, Philippines, and you see that you go to these rural areas and women are still cooking with firewood. So you see people, they will come with COPD, and if you ask them, did you smoke? No, of course I never smoke. And now they're visiting you in LA. You see somebody with COPD, you will assume that, oh, it's a black woman, she smokes. Oh, she's not a black, that's not how you make a diagnosis. Right? Talk to the woman. Find out where she's from. Find out what she did for a living. Don't make assumption. Right? And then you realize, oh, she's from the village somewhere in Kumasi and she did cook with firewood for all her life. Or she used to sell food by the roadside and she cooked with firewood. Or she works in, what is that other Mexican stand where they sell roasted meat all the time, right? Those people are inhaling smoke all the time, right? So you talk to the people. You know, it looks like COPD, there is no history of smoking, then it's an occupational exposure. Probe the occupation, okay? Don't always stop on current occupation. Ask people, what kind of job have you done in the past? Because somebody that was doing roasted meat and shish kebab for sale and stuff like that for 30 years, now they can't breathe, now discover that they will probably do better as a security guard. They will tell you, I'm a security guard, although they don't call them security guard anymore. They call them loss prevention specialist. Yeah. So the guy will tell you, I'm a loss prevention specialist in RAF. Don't stop there, say the guy is a loss prevention specialist. No. How long have you been a loss prevention specialist? It's not like just like 6 months ago. What did you do before then? He said, well, I worked in a Jamaican restaurant making shish kebab. Then you know where your COPD came from, right?
Combination.
Exactly. So, although 80 to 90% is due to smoking, Among immigrant women, recent immigrants, smoking is not likely to be the cause. You have to look for other reasons. And occupational and environmental exposures are important. Okay? Now there is this condition called alpha-1 antitrypsin deficiency that can also predispose to COPD. Alpha-1 antitrypsin is really one of those enzymes, it's a control enzyme. Whenever the neutrophils release their protease, the inflammatory enzymes that break down stuff, alpha-1 antitrypsin is one of those enzymes that neutralizes those neutrophil enzymes. So when you don't have alpha-1 antitrypsin, the destructive enzymes linger for a long time and they cause a lot of damage. Okay, so people with alpha-1 antitrypsin deficiency are at risk for COPD. Alpha-1 antitrypsin is made in the liver, but it's actually working in the lungs. People with alpha-1 antitrypsin deficiency, they make the alpha-1 antitrypsin, but they cannot release it into circulation. So the lungs does not have it, lungs get destroyed. The alpha-1 antitrypsin remains trapped in the liver and causes liver damage. So whenever you see somebody with COPD and you do a comprehensive panel on them and liver enzymes are elevated, you should step back and say, am I dealing with alpha-1 antitrypsin deficiency? You understand what I'm saying, right? Good. So COPD with liver enzymes elevation that you cannot explain otherwise should clue you in to alpha-1 antitrypsin deficiency. Thank God it's not very common, but you should know about it. So this is what I'm talking about. You smoke, you cause inflammation, you activate neutrophils. Neutrophils release the proteases. Usually the proteases are inactivated by things like alpha-1 antitrypsin, and inflammation keeps going, and that's how you get chronic bronchitis. If you have alpha-1 antitrypsin deficiency, you're not able to inactivate the proteases. So the elastase, which is one of those destructive enzymes that is released by the neutrophils, continue with the destruction, and you end up with tissue destruction. I tried to explain it here, but I already talked about it. Remember, COPD is a composite diagnosis of chronic bronchitis and emphysema. Many times in practice, we're able to tell when somebody has chronic bronchitis versus when they have emphysema. But more often than not, you will not be able to tell the difference. When we are not able to tell the difference, we call the patient COPD. When the difference is clear, we call it chronic bronchitis or emphysema, if you know it. Now, let's talk about how you make those distinctions. Patients with chronic bronchitis present with chronic cough. Patients with emphysema present with dyspnea. Ultimately, everybody coughs and are dyspneic. It is what starts first that is important. In chronic bronchitis, it is cough. It is a daily cough. They call it cigarette cough. The smokers themselves know it. Anybody smokes in this room? Oh, good. Nobody smokes? Okay, no. Good. So daily productive cough for 3 or more months of the year and for at least 2 consecutive years. So you see, you cannot diagnose chronic bronchitis from 2 visits, right? You have to talk to the patient, take a history of the cough, right? In order for it to be chronic bronchitis, the patient must have coughed for at least 3 months for 2 years back to back. And usually the cough is productive of copious mucus, yellowish, gunky crap. They cough up, right? It's a lot of it. That copious mucus production is what is called bronchorrhea. It's the bronchial equivalent of diarrhea. Okay?
Bronchial diarrhea.
So it's called bronchorrhea. Now, there is another condition. What? Something you need me to clarify?
No, sir.
Okay. Now, there is another condition I need to tell you. There is another condition called bronchiectasis. The way you tell bronchiectasis from chronic bronchitis is in bronchiectasis, they have hemoptysis, right? And generally with bronchiectasis, the amount of sputum varies with position. Okay, but we'll get there when we talk about inflammatory lung diseases. or lung infections. I'm just getting your feet wet with that. All right. So bronchorrhea is what that is. Then they wheeze from bronchoconstriction and edema of the bronchial mucosa. They wheeze. Finally, they become dyspneic. After the onset of cough, you have dynamic hyperinflation. What is dynamic hyperinflation versus static hyperinflation? With dynamic hyperinflation, that is what you get in conditions like obstruction, like asthma, where the patient is able to take a deep breath because inspiration is voluntary, you can influence it. But then, because of the obstruction, expiration is prolonged in such a way that the patient is not able to completely exhale before taking in the next breath. So they stack up breaths. Okay? Now, that is dynamic hyperinflation. Static hyperinflation is when the lungs distend and because of loss of elasticity, is not able to recoil. Okay? So in both cases, the patients come to you like this. They look like they are working out and everything, but talk to them, they are dying, basically. So, emphysema patient, they begin with shortness of breath. They have static hyperinflation. They have no wheezes. They don't wheeze. Because there is no airway obstruction, there is no bronchospasm. Remember, the problem in emphysema is in the alveolar. It is the alveolar walls that are broken. And because the alveolar walls are broken, the reason they are short of breath is because the surface area available for gaseous exchange is reduced. Right? You understand what I mean by surface area, right? So think about it. If I have a cavity like this, where everything here is lined, see how much surface area there is for air exchange? If I now have the same cavity, now it's like this. Because some of the walls are broken down. This is less surface area. Right? So the reason that emphysematous patients are short of breath is because there isn't enough surface area for gaseous exchange. So that's why they are hypoxic and they're dyspneic. Okay? Good. So, cough is less common, less productive, less prolonged, and comes much later. So cough is not a big part of the reason. So when somebody comes to you, say 20 or 30 pack here smoking, and they say they're short of breath, and you ask them, any cough? They say, no, not much of any cough. Leg swelling, no leg swelling, no autopnea, no dyspnea. All you have is 30 pack here smoking, or it was a coal miner, or you worked on the farm, then you know you're dealing with this might be emphysema. You don't need to call that COPD. The history is so typical that you are okay, you should call that emphysema. Right? Oh, come on. How does it present? Respiratory failure, everything we talked about. Use of accessory muscles, hyperinflated barrel chest, auscultation, reduced breath sounds. If it's bronchitis, you get a wheeze. In emphysema, you know what you hear? When you try to listen, under normal circumstances, the breath sounds sound like this. Inspiration. Inspiration and expiration is continuous. There's no gap. If you sense a gap, that's what's called bronchial breathing. Okay. In emphysema, when you listen, it's like this. They are not able to move air. Because air is not moving, you just get not, right? It's the duration of the movement is like the air, the patient is not moving air. Even though they are trying really hard, flaring, trachea tugging, all these recessions, abdominal movement, they're doing everything they need to do for air to move, but air is not moving. Okay? And because they have to use all these muscles to breathe, they tend to be lean. Okay? And they have this pulse width breathing, central cyanosis, where they're about to die. Reduce cricosternal distance, you know what that means. Okay? Intercostal ingroin, cardiac apex is not palpable. You know why? Because the lungs are so hyperinflated, it's wrapping around the lungs. wrapping around the heart. So the cardiac apex, they're supposed to be palpable in the chest wall, it's not there. because the lungs are enveloping the heart. Okay? And then inward movement, low and flat diaphragm. That's bad thing. In the old days, we used to call emphysema the pig puffers, and we used to call the chronic bronchitis the blue bloaters. We don't use those terms anymore because it's name calling. It's insulting to patients. So we have a blue bloater in room 6. Right, so, but these are important differences between emphysema and chronic bronchitis. Okay. I'll give you a little bit more information on why the pink puffers, the emphysematic patient are like this. They have this thing called S rages. This is advanced pathophysiology, but for those that can handle it, soluble receptor for advanced medication end products. They are what you call pattern recognition receptors. I mean, at times, it really, for research purposes, it's important for you to tell chronic bronchitis from emphysema. And that is when we do stuff like that. Please don't go and order S-raging practice. They'll ask you, which planet are you from? Okay. Diagnosis. How do you diagnose COPD? Well, symptoms, history of exposure, you look for smoking. Anybody with more than 20 years of smoking is at risk for COPD. Okay? Family history of COPD, you must think about antitrypsin deficiency. Okay? My mother smoked and died of COPD. That was why I didn't smoke. I don't know why I'm having COPD. Alpha-1 antitrypsin. So I might give you a question like, which of the following tests is appropriate in a 60-year-old patient with COPD with an history of smoking? My mother died of COPD at 74. And I'll tell you, chest X-ray, antitrypsin and deficiency, glucose. I'll give you a kind of crack. You need to just look, make sure that if somebody has COPD and a family history of COPD, but if you don't smoke, that means you have to look for occupation or family history. Family history is positive, that is alpha-1 antitrypsin deficiency. Occupation is positive, it's an occupation of lung disease. They qualify for disability. That's strange, right? If they get it on the farm or from their occupation, they'll qualify for disability. But if it's a family history, you're going to have to fight the Social Security Administration to get them qualified. Right? Okay.
Sorry, if it's occupational, you said it was a respiratory.
I say when it's occupational, you can get them qualified for disability very easily. But when it's alpha-1 antitrypsin, it's a family disease. It's a little bit more difficult to get them qualified for Social Security disability. You can do it, but they will put you through the changes.
Will they check their family if they don't have it? Or is
You
it
mean Social Security disability people? They don't. You have to now make the case to help the patient. You have to actually call sometimes. Yeah. If you don't, the patient doesn't get it. Many of those homeless folks you see all over the place are medical cases that nobody advocated enough for them and they lost benefits. Many of them veterans of the army. Okay. So symptoms, dyspnea, progressive, chronic cough, sputum, remember, only for chronic bronchitis. History of exposure, smoking, more than 20 pack year of smoking, we'll talk about how you calculate that. Family history, extremely important. Spirometry is required for diagnosis and the parameters are the same, exactly like asthma. The only difference, reversibility. Okay? How do you calculate pack years? Divide the number of cigarettes smoked per day by 20. There are 20 cigarettes in a pack, since none of you smoke, so you should know that. There are 20 sticks of cigarettes in a pack of cigarettes. You now multiply the number of packs smoked per day by the number of years smoked. So you report that as pack years of smoking. An example, a 42-year-old female smoker who smoked a pack of cigarette a day from age 16 to 36 has smoked for 20 years, right?
Yeah.
So, and 1 pack per day, so that is 20 pack years to start with. She then stopped for 5 years and started back 2 years ago, half a pack a day. So what is that pack is? 21 pack years, right? You got that? You should know that because you'll be tested on that one. Everybody tests. I don't know why everybody tests you on this one. I've seen it in one shape or another. So, extremely important. One thing you need to know, the lungs never fully recover from the damage effect of smoking. You lose your pulmonary reserve with smoking more than 20 pack years. So even if you don't know it, so your patient may not have COPD. If they have more than 20 pack years of smoking, lungs are gone. They have no reserve. Those are the patients that will their cold will linger longer. When they develop pneumonia, not only do they develop pneumonia earlier, it takes a longer time for the pneumonia to resolve completely. Because under normal circumstances, all of you sitting in this room, you're functioning with only half of your lungs. You don't need 2 lungs. That's how you can do pneumonectomy. Some people take the whole lung out and they will still live and be fine. You don't need both lungs. Because whoever designed it was very aware that there will be a lot of respiratory insult. So you only need half of your respiratory capacity at any given time. But when you smoke, you damage the capacity. You're using your whole lungs. So when you now get cold or pneumonia, you get sick very quickly. You will never find somebody with 20 pack year smoking as a walking pneumonia. It doesn't happen. The reason you have walking pneumonias is because you have pulmonary reserve. So they're not sick, even though they have pneumonia and they can do whatever they can do. So you call them walking pneumonia. If they are smokers, it cannot be walking pneumonia. You will be just pneumonia. I will be dying pneumonia sometimes. So smoking cessation is very important if you have somebody with a significant history of smoking. And it's interesting, I think somebody, CDC or somebody put this out there on the benefit of smoking cessation. They say in 20 minutes your heart rate returns, in 2 weeks, I don't know. I had space there and I want to put it. So I put that there. You can take a look at it. I think it's fun. Because I find out that at the end of how many years you can actually save like $50,000. You can reduce stroke rate by 50%. I mean, some important statistics. But I won't test you on that one because that doesn't have anything to do with pulmonology. Well. So like asthma, remember in asthma what we do, we diagnose, we assess severity. Remember? The same thing we do for COPD. We diagnose, we assess severity. COPD, how do we assess severity? You do the COPD assessment test, CAT. So it's a scale of 1 to 5. You ask the patient, I never cough, yada. And then you grade it based on this Medical Research Council Dyspnea scale, grade 1 to 5. All of these together are related. You're trying to assess the quality of life on the patient. Okay? I don't do it because most of my patients that have COPD are still smoking. So I'm not motivated to assess disability. And people fault me for that. If I have somebody that is actively smoking and they develop cold and they're asking me for antibiotics, I don't give antibiotics. So don't do it. But a smoker with a cold, I won't give you cough syrup either. And the reason I don't do it is I like for them to feel the impact of the smoking. See, if I keep throwing things at them like that, they think it's okay. And a few of my patients have left me because of that. I'm fine with that. I'm not going to eat and abet nonsense. You have COPD, we all know you have COPD, you continue to smoke. One day you're going to die of COPD, and it's going to be my signature on your death certificate. I remember every single one of them. My goal in life is to make people healthy, not to watch them die. So generally patients like that, I disengage. And the way I discourage them from coming to see me is by not responding to their demands like that. I'm not recommending that you do that. I'm just sharing information. Now, there was this big deal thing that the WHO got a bunch of guys together and everybody makes this big deal about it, and I find it like ridiculous because in practice it's really useless. It's time consuming, time wasting, completely futile. It does not really influence your therapeutic decisions. Why are you disturbing me with this thing? But they will ask you. So you need to know it. I don't need to know. I just have to tell you what it is. It's called Global Initiative for Chronic Obstructive Lung Disease. Global. That means they got everybody from the world. So people often talk about gold risk stratification. The gold is not jewelry. It's Global Initiative for Chronic Obstructive Lung Disease. Right? So the idea is, it's a way of standardizing the way we assess the severity of COPD. You know why we do this? Research. When pharmaceutical companies want to prove that the inhaler is better, they need a way to recruit patients that are at the same level so they can show efficacy. It's all driven by pharmaceutical companies. That's why I'm not motivated to talk about it. But I think we need to understand it. So it's a way of assessing severity. So what they say is, okay, fine, post-bronchodilator. If you have FEV1 more than 80, they call you gold 1. Between 50 and 79, gold 2. 30 and 49, gold 3. Less than 30, gold 4. But it's not as simple as that. See what it is here. So what they do is you create this. What is this 2x2? You all know. Have you done research on methods yet? No, okay, so you have this 2x2, right? So this is the Medical Research Council category, the one we talked about, the scale, right? This is less than 10, this is more than 10, right? This is exacerbation history. More than 2 hospital admission, 0 to no hospital admission. So group A are people with no hospital admission, less than 10 from the previous assessment test. Group D are those with hospital admission and more than 10 Medical Research Council scale and all that. So in that A, B, C, and D is a summary of all of that nonsense. Okay? The reason I don't find it useful is because exacerbation history. In SPA 6, you have a COPD patient. The only thing the patient can tell you is that I was in the hospital. They can never tell you what they were in the hospital for. Oh, I was short of breath. Were you short of breath because you had pneumonia? Or were you short of breath because you have COPD exacerbation? Or were you short of breath because you had asthma? Because you had asthma and you smoke? I don't know. You know what I mean? So it's difficult for me to use this thing, right? But many times, they will, in the exam, they will tell you, oh, COPD category D. Just know that's a very bad patient. Bad patient. Frequent flyer, they call them. They're always in the hospital. And group A, category A, mild disease. Okay, and you need to know how they derive those categories. I will never ask you anything on this, okay? How do you treat COPD? Exactly like asthma. The only difference, steroids are your last. You see, this big thing looks complicated, but I've summarized it in this box for you. Okay? Short-acting bronchodilators, SABAs and SAMAs. Remember, we didn't use SAMAs in asthma. Okay? We don't use muscarinic agonists in asthma. We don't. Only in COPD. All right? And then you go straight to long-acting. Whereas in asthma, the steroids for long-acting. That is an important difference you will not forget. The use of short-acting muscarinic agonist and long-acting beta agonist before steroids. So, mild, see, everybody get the short-acting, everybody across. Once you begin to go to moderate, you're adding long-acting bronchodilators, and you begin pulmonary rehabilitation at that point. And then steroids is the last thing. And sometimes you may have to use oxygen therapy. You guys want a break? Well, thank you. I figured. Okay, so it looks complicated, but I've just told you what it is. It's SABAs and SANAs, then LABAs and LANAs. Steroids, last option. Even though it looks so like simple, you'll be amazed at how frequently that question is tested. You don't want to give an asthmatic patient a muscarinic agent unless they smoke. And you're thinking COPD.
Unless they smoke.
They smoke. And you're thinking COPD. Okay? So if you're going to give somebody Atrovent, please make sure your diagnosis is not asthma. Okay? Make sure it's COPD. Because the plan will not approve it. And if the patient needs it, it's not going to get it.
Can I ask a question?
Yeah.
Is it the same if it's just emphysema or just chronic bronchitis?
Yeah. the same. That's why we don't distinguish with COPD.
It is, okay.
So just to repeat what you said SAMA you don't give for asthmatic patients.
Unless they smoke.
Unless they smoke, which then it would turn into a COPD.
Oh, yes, exactly. That means you're treating the COPD, not the asthma.
So
Okay.
SABA or SAMA?
SAMA. The muscarinic.
Short-acting muscarinic agonist. Now, remember COPD includes emphysema? I remember it, yeah.
Sorry, was it SABA and the SAMA, or you do or?
You do both, actually. Combivent is a combination of both SABA and SAMA, right? Yeah. Okay. So you go SABA and or SAMA, and then the next stage, if you just make any better, LABA and or LAMA. Then inhale congestions, right? Medium dose, low dose, high dose, right? Now remember that emphysema is not inflammation, it's destruction of the alveolar walls. So most of the time, all this your SABA LAMA crap will not work. Ultimately, your patient is going to need oxygen. Okay? And you have to prescribe oxygen for them to carry home. And you need to know when oxygen is indicated. So when your patient comes to you short of breath and they have no cough, and they're tachycardic and they have emphysematous chest and EKG has low voltages, and you know this is emphysema and the patient is going to need oxygen, you have to do blood gas or room air. Oxygen is indicated if your O2 sat is less than 88 or your PaO2 is less than 55 on room air. If you want your patient to qualify, you do the test after they have exercised. Okay, you tell them to walk around the clinic like 3 or 4 times, and then you do the test. Because they will short of breath, so they can qualify. Because most of the time, the patient will fall between 55 and 60. When the PaO2 falls between 55 and 60, Medicare requires you to have additional stuff. You must show that the hematocrit is more than 55, right? Or that on the EKG, there is evidence of pulmonale. Either you have right ventricular hypertrophy or right atrial enlargement. It's very clear. PaO2 less than 55, you're good to go. When PaO2 is between 56 and 59, you need to have secondary erythrocytosis and or pulmonale. And pulmonale is from EKG, right atrial enlargement or right ventricular enlargement. You must have those. So let me ask you, Wendy, is the right ventricular hypertrophy a requirement for home oxygen? Yeah, for home oxygen. Is right ventricular hypertrophy a requirement? No. Only when PaO2 is between 55 and 60. Okay? Get that. All right. And then it comes in all kind of shapes. Some get it in cylinders, some get it in concentrators. You don't decide what you should do. You just say home oxygen is indicated. The plan and the medical supply people, they work together and they give the patient something. And some patients have been burned to death because they smoke with oxygen. When I was an intern in this hospital across the street, we actually had a fire on the floor, and that patient was killed because he was smoking with wall oxygen.
Oh my.
You won't believe the kind of things people do. Addiction is possession. Because if you really do stupid stuff, and the goal is to destroy it ultimately, right? Home oxygen is so good and very effective. Look at this study, nocturnal oxygen therapy trial, England, and then the one from just US, and then the Medical Research Council trial. Look at the survival difference between home oxygen and people that didn't get it. The red line are those that get oxygen. It does help survival. So if your patient needs it and it's indicated, make sure they get it. Because if they don't, they will die sooner than they should. Okay? Nobody will know because they will die at home. But something in you will convict you when that death certificate comes and asks you to sign. Because every time somebody asks you to sign a death certificate, the question you will ask yourself as a provider is, did I do everything I could? And when you find out you omitted something, believe me, it stays with you for a while until you become numb to it. And I hope you never become numb to people dying under your care. That would be good. Like Kevorkian. You all know Dr. Kevorkian?
Assistant.
The guy that was putting people to sleep, thinking he was doing them a favor, and they put him in jail. They warned him, he won't stop. He keeps thinking they're suffering. I'm like, what is your problem? You're a physician, for Christ's sake. Your job is to alleviate suffering and help people live. Not, people can kill themselves when they want to. They don't need you to do that. So this is a table, just a summary table for what are SABs and all this crap we're talking about. SABs, albuterol, and what they call pro-air preventive ventolin, levobuterol, Zopinex, long-acting formoterol, afinitrol, sometrol, indapamide, short-acting SAMs, ipratropium bromide is the only one there is, right? And long-acting anticholinergic, Spiriva, Todosa, combination, combinant, talked about metazantines, theophylline, amylotide. Just a table to remind you what is available and stuff like that. You don't need to memorize that, okay? Just know the class, okay? Pulmonary rehabilitation is extremely important for COPD patients. Pulmonologists do it, and then you send your patient. It's a lot of stuff. It includes baseline assessment. They have an action plan. They manage their comorbidities. They teach them how to breathe and how to exercise. They give them nutritional support. Remember emphysema? They are often lean because it's a workout just to breathe. Then they teach them how to conserve energy. And not just one person does this. Nutritionists, pulmonologists, respiratory therapists, everybody is involved in pulmonary rehabilitation. It's very important. When can't you do it? Don't send anybody with ischemic EKG changes to pulmonary rehabilitation. Don't send anybody with unstable angina. Don't send anybody with recent heart attack, 6 months. Acute pericarditis, pulmonary embolism, high blood pressure, second aneurysm, acute infection. These are contraindications to pulmonary rehabilitation. They cannot do what they are required to do with pulmonary rehabilitation safely under these conditions. Okay? So you are putting them at risk. Don't do that. Okay? And it's very easy for this to happen. The only thing that is required for somebody with a recent heart attack to be put into pulmonary rehabilitation is your failure as a primary care provider to disclose that information on your referral slip. If you don't disclose it on your referral slip, they will not know. Okay, that's why it's extremely important that you know. You can give your consultants or specialists enough information so they can make the right decision for your patient. Complications of COPD, type 2 respiratory failure, chronic hypoxemia, pulmonary hypertension, pulmonale. We talked about this already, right? Emphysema, see what will happen. That bleb can rupture and give you pneumothorax right there and then. Somebody has pneumothorax, they get in a fist fight, somebody punch them in the chest, they can develop pneumothorax right there. Okay, extremely important. Want to say question or question? Oh, okay. So remember that ruptured bleb or bullae is the reason for pneumothorax, and it could be a blunt trauma to the chest. It's all you need to get pneumothorax. Okay? Get two guys got in a fist fight, and the other guy punched the guy in the chest, and he went into pneumothorax and he died. It's not the power of the punch, it's the bleb. Most of the time is the lungs. Or somebody who smokes, who has COPD, now goes to use cocaine. You know, when they snuff cocaine, right? They use some serious inhalation force. that is sufficient to rupture the bleb. So, and who are the guys that does this stuff? They are the chronic smokers, right? Then now when his time is up, we'll go and use cocaine, and that's the end of him right there. And you will be amazed how many people are dying around us of stupid stuff like this. So you do yourself a favor when you see your patient that is a COPD and you see that his tox screen is positive for cocaine, tell him, you know, you'll be better off shooting it than inhaling it. If you know, the truth is that he's likely to kill himself faster with the inhalation. He's like, look, if you shoot drugs, you get advanced vascular aging. So if you're 40 years old and you shoot drug for 10 years, your vascular age is 50 years, right? That same thing doesn't apply to lungs. You pop that bleb, you're dead. Because the truth is, when the bleb ruptures, it becomes a flap.
That's a quote.
You see, when the bleb ruptures, it ruptures into like a flap. So you have the bleb like this, it ruptures, and then it overlaps like that. So it leaks air into the thorax, and it doesn't allow air to go back. So almost always it's a tension pneumothorax. And because it's a tension pneumothorax, very quickly the thoracic cavity becomes positive and no more venous return. When there is no more venous return, hypotension, shock, loss of consciousness, death. That's it. Very quickly you'll be dead. Okay, so I'm not kidding when I say, if you know your patient has COPD and you know he uses drug, tell him this drug is going to kill you. It will kill you faster if he keeps nothing. Look, all I want to do is help people live. Even if it is 2 years longer, I'll be fine. I mean, I tried my best. I will sign that death certificate knowing I tried my best. He was determined on dying. Yes.
I'd like you to please review the X-ray for us.
What does he have to review? This is the pneumothorax. This is the positive pressure in the pneumothorax collapsing the lungs, and this is the lungs. That pleural outline is the lungs. This is air. And the way you see it is, when you look in the pneumothorax, you don't see lung markings. You just see that smooth background. Okay, I think that guy that comes on Mondays in the night is supposed to do this, right? Doesn't he do it? Yeah, but okay, you see, when you look at this, the way you know this is pneumothorax is because it's very smooth. That is air. And the way you know it's a tension pneumothorax is because it's compressing the lungs. Only a tension pneumothorax will do that. So this is the lungs right here. That's why this outline here is the collapsed lungs. Lower lobe, upper lobe, middle lobe. This is normal lungs. You see those lines? You could see the pulmonary vascular markings in the normal lungs. In the pneumothorax, you don't see any vascular markings. You know, I am not in support of you guys learning, other than going through X-rays in classes like this. I don't like that lecture you guys go to because there is something about that class that scares me. I don't want you to walk away with the impression that it's okay for you to read chest x-rays, because I do. Because if you miss anything, then you're liable. Always treat your patients with a radiologist report. It's okay for you to pick up something on the x-ray that the radiologist missed. No problem. But the day you miss anything, how many lawsuits does it take to sink a clinician? So I'm nervous about that class. I don't know what the objective is, but I just want to share that with you so you know. This is a very treacherous
I
landscape.
think it's just to give us
Yeah,
exposure.
he said the same thing,
Like, you've been telling us, like,
So we know what to order.
I got you.
Yeah,
Okay, that's
just
good.
for
Okay.
exposure.
So you know what to do, chest x-ray, CT scan, and all that.
Yeah.
Then I need to sit in the class. All right. Cachexia is linked, is like totally harder than breathing. That is completely not of breathing. Okay? All right. I think I'm done. So we're going to do some questions. I'm going to start with you, Stephanie. Which of the following anatomic structures marks the beginning of the intrathoracic upper airway?
She wasn't here. She wasn't here. She wasn't here. She wasn't here.
That's what you get for coming here. You didn't call me. You didn't text me.
I know, sorry, I got the message actually on my phone.
No, seriously?
Yeah, I got the message.
Okay. So, let's go to the rescue. 6:30 herring. Okay. Crystal, which of the following features can be used to differentiate? Pierre asked for a break, right? Give me specific names. Okay. Crystal, which of the following features can be used to differentiate bronchial asthma from chronic obstructive pulmonary disease?
All of the above?
Thank you. Very smart. You see, in the class, we didn't talk about DLCO, but I told you about methacholine and histamine challenge test. That is one of the things you need to learn, exam taking skills. You don't have to know everything. If all of the above is there, and two of the answers are already correct and you're sure, then that third one is correct too. Right? So all of the above. Good. Eden. Which of the following conditions is not the cause of an upper airway obstruction?
The right main bronchial.
Thank you. Right main bronchial tumor is not an upper airway obstruction. Okay. Annie.
That was Kia. Disclaimer, Kia threw names out, not me. Wow. Okay.
What was that?
Everyone's looking at me because they're.
Oh no, it wasn't like that.
I just
It wasn't like she came to me in my office and said, you need to call this. They were all sitting there. And she said, why do you always call me? Why don't you call other people? And I was like, oh, okay. So yeah, he's actually protesting. So let me honor that request before I go back to them. So, anyway, which of the following is exclusively associated with an extrathoracic upper airway obstruction? Inspiratory stridor. Everybody agree with that? Yeah. Okay. Wendy. Methacholine provokes bronchoconstriction by stimulating which of the following receptors? Class to the rescue. David. Methacholine, muscarinic. Yeah, muscarinic receptors. hearer. Which of the following floor description is consistent with a fixed upper airway obstruction? Inspiratory flow plateau, expiratory flow plateau, inspiratory expiratory plateau. All of the above, none of the above.
B, all of the above.
Fixed.
Why wouldn't it be if it had?
Fixed.
So wouldn't it have, what?
Remember that picture from
It is
So it's both. So it's
Oh, I see what she's saying.
the question is, which of them is consistent? Consistent. Okay. So, inspiratory is extrathoracic, usually. Expiratory is intrathoracic, typically. When both of them become advanced and they cause fixed obstruction, usually it flattens both inspiration and expiration. So, inspiratory and expiratory plateau is a sign of fixed airway obstruction.
Yeah, but then it says all of the above, so it's.
Right.
still
It includes
has
both
an
of them.
inventory, It still has an
It's still,
expiratory.
yeah.
It has all of them.
The question is, the answer's choice. You shouldn't have it all the above.
Oh, wait a minute now. Listen. Are you telling me that a fixed upper airway obstruction will cause inspiratory flow plateau by itself?
No, but it will cross it with answer B. It crosses A with B.
Yeah.
All right, I'll put all in.
Yes, that's different.
Okay. All right, back question. Stanley, which of the following is not a clinical feature of an upper airway obstruction?
Wheezy.
Wheezy?
Which of the following is not? Wheeze, right? You said?
Yeah.
Anybody think different? Anybody think different? I mean, a wheeze is not part of the upper airway features, right? His voice changes, noisy breathing, shortness of breath. Wheeze is not part of it, right? Okay.
Is that Yeezy's cousin?
Lorraine, which of the following is the primary purpose for racemic epinephrine in the treatment of acute airway obstruction? Racemic epinephrine, 1 in 100,000 by inhalation. What does it do for airway obstruction? Everybody agree with B? It's all of the above. Again, remember what epinephrine does is vasoconstriction. So by vasoconstriction, it reduces blood flow to the surface. By reducing blood flow to the surface, it causes mucosal dryness, right? And it will reduce the mucosal edema. And because of reduced blood flow, the goblet cells don't have enough blood to make any secretion. I know you should be able to figure out reduce mucus secretion and mucosal edema. Lung compliance, it does. Even though we didn't talk about that, but these two are correct. So all of the above is the answer. All right? Jason? Which of the following is the next best step in the management of a 48-year-old male with a history of COPD, admitted 3 days ago for COPD exacerbation, but now stable on 2 liters per minute of oxygen? What are you going to do now? B? You said B?
No.
B. No, because he's on oxygen.
What are you going to do? The guy is 3 days ago was admitted. Now he's no longer short of breath, but he needs to be on oxygen in the hospital. So he's going to need oxygen at home. So you're going to need to do some things to assess, to make him qualify for oxygen at home. So how many of you will do arterial blood gas? Alone? Only you will do it. It's all of the above. Because you know the truth is, you want to do everything you need to do now to qualify him for oxygen. Because if you just do blood gas and his PO2 is 55, you're good. But what if the blood gas comes, PO2 is 58? Will you not say, oh no, please, I need EKG on that patient? Or is that what you'll be saying, I need CBC? You don't, CBC you have to draw and send to the lab, right? So it's going to delay your discharge. And that utilization review nurse is going to be on your tail.
But I thought you said you did do all of it unless the one criteria by itself wasn't enough.
I know, that's because you don't know how your patient is going to land,
So
right?
You just do it ahead of time.
What does it take? I mean, the guy is already COPD. If you do CBC anyway, you could have been pneumonia, so you would have done that, right? EKG, you just do, it doesn't cost anything, just a piece of paper, less than a penny.
So is it just because he has COPD, or are you just telling him?
No, because he's going to need home oxygen.
Yeah.
And for home oxygen, if he ends up with PO2 of 55, he will qualify. But supposing the PO2 on oxygen come back to be 58, you need to show that he has secondary epicytosis or he has pulmonale. So this allows you to have everything once at a go. And it's not expensive. All of these are in-house tests. Say it again?
So like when you asked when you that question earlier, you said like, if I ask you which one is like a routine home oxygen test, it would just be like the PO2. But now you're saying that we should just do it. We should do it all, right?
No. In asthma,
Yeah.
none of this
Oh,
matters.
this is COPD.
Yeah,
This is COPD.
Okay.
Asthma never need home oxygen.
Okay.
COPD need home oxygen sometimes, especially the emphysema cases, right? And in order to qualify, you want to get the test done once and for all. Because you know the reason you have to do it is because when your patient is stable on that last day, they expect you to send the patient home. So you're supposed to do discharge planning from admission. So you need to make sure you do the CBC and electrocardiography. You know, because it's bedside stuff. 1 hour you're done. The CBC might take a little longer. If you didn't think about it and you wait till the last day, it might delay a patient for another 6 hours. If that home closes or your discharge nurse goes home, that patient stays an extra day. And depending on what you need, it could go up to $5,000 a day. You can increase the healthcare cost. So generally speaking, all these routine tests, for COPD patients, just get it done. So when it's time to send the patient home and request for the home oxygen, you have the information. Okay, so here is all of the above. Okay. All right. So which of the following clinical features is characteristic of chronic obstructive pulmonary disease? Did you say C as in cat or D as in David? Characteristic of COPD.
I said E.
E. None?
I'm sorry, C.
C, exactly. Because COPD is a chronic condition. You don't need any challenge test. So both of these are wrong. But the only difference between COPD and asthma in terms of pathophysiology is COPD always have reduced diffusion capacity. Diffusion capacity is always normal in asthma. Because remember, in asthma, lungs are normal. It's the airway that's obstructed. Okay? Right. So, the answer is reduced diffusion capacity for carbon monoxide. Okay? Any questions? You're good with that? Are these complicated questions?
You have to give us time to think.
Yeah, of course you have to think about it. I mean, I do this so I can screen out bad questions on your exam. Nobody should fail a test because I put a bad question out there. That is not okay. Okay, so I do this to make sure that we screen the question and everything is good. All right, Alex, which of the following is a sign of severe bronchial asthma?
Normal PCO2. B.
Good. Christian, which of the following conditions is considered a reversible obstructive airway disorder?
Just FYI, it's 11:03. I know you had a meeting at 11.
Thank you.
Is it B?
It's just this box.
Yeah, broken asthma. Wait, that clock is not correct?
No, it's 11:03.
All right. Which of the following is likely to be seen 46-year-old yada yada yada?
Positive. All of the above.
Good. All of the above. Histamine provokes bronchoconstriction, David, by stimulating weak chronocolin receptors. H1. Muscarinic 3 for methacholine, histamine H1. Justin, which of the following is likely to be present in a 56-year-old male with a long history of COPD and a more recent onset of leg swelling and dyspepsia? Thank you. Very good. That is how pulmonary presents. Okay? You have a loud P2 because of pulmonary hypertension, right? You have a hepatomegaly because of venous congestion in the systemic veins. And you have the right ventricular hypertrophy and EKG. All of that is called pulmonary. Well done. Bradley, which of the following is an indication for long-term oxygen therapy?
So that's like home, right?
Like home oxygen, yeah.
It has.
Huh? Did you say B? Yeah, that's it. That's it, B. Okay, what is the estimated park years of smoking in a 68-year-old? 40. Tarika, give me the answer to that one. I gotta go.
60-year-old adult.
Okay, just blow the answer out if you have it. 45, Tarika, you agree? I don't know.
35.
Okay, 16, the guy smoked a pack from 16 to 56. How many years is that?
That's 40. It's 45.
That's 40, right? Then it's not for 10 years, and start back 2 packs a day. After the date of half a year ago. So what is that?
35.
Thank you. I'm on my way.
Oh, okay.
All right, that's the last question. Good luck.
Yes, it was because it was 4 but she stopped for 10 years.
That is arithmetic. That is not what my class is about.
Yeah, that's,
We don't have 2 packs.
2 packs after 2.5 years. So
A year and a half.
two.
This is pulmonology, not arithmetic.